ourselves and be sending messages privately if you have any questions, and be on the on your WhatsApp too. I may be sending messages there.
Hello, everybody. How are you all? Yeah, so I welcome all of you to our third series of our webinar, and I really want to thank you all for making time to join this very, very important program. And then I know that by the time we are done, we all go back to our society to make our wards better, educate people on the essence of respectful mother care, and we ourselves will be enriched with the necessary knowledge that we can impact. We will be starting shortly, so I want to unofficially welcome all of you to the page, and then we will be starting shortly. Yeah, thank you. All right, good day to you all. It's good evening in Ghana, and it's maybe either a good morning or a good afternoon from wherever you are. And no matter the time of the day, I really welcome you to the third series of our mini webinar series on respectful maternal care. So my name is Owusu Benson, and I'm going to be one of the moderators for today. I am a nurse by profession, a lecturer with the School of Medicine, Central University, and also a PhD candidate in public health. And I love issues concerning women. So that is about me. That is what I do. So I also have my co-moderator here who would be, I would really want her to introduce herself as well.
Thank you, Benson. Hi, everybody. Thank you for joining us. So my name is Isabella Gatti, and I'm a midwife, and I'm also a PhD candidate. My research is actually focused on midwifery management of preeclampsia. So this promises to be very exciting. We thank you for joining us, and we are just going to have a very good time. So Benson is going to take us through the practicalities involved with this webinar and just general information, and then I'll introduce the guest speakers and then we proceed. Thank you very much.
Right, thank you, Isabella. So with the Zoom practicalities, to avoid disruption in the course of the program, I really want to ask all of you that we put our microphones on mute so that there are no disturbances whilst our presenters are presenting. Now, if you want to ask any question, when you look down, okay, you'll see a button at the lower part of your computer that is written chat. So once you click on that, you should be able to put any question that you want to ask. Now, once you put in your question, we the moderators will ask you to unmute or will help unmute you. Then you ask your question. It is also very important to know that the meeting will be recorded, and then we'll put it on the APECGH website and our social media platforms, as it's currently being it's on Facebook Live, it's on social media now. Now, if in any event, if you don't want your name to be visible, we really ask that you turn off your video, or you can make your name anonymous as well. Yeah, so this are the practicalities I really want all of us to strictly adhere to, so that we can really work with time. I really want to now leave it for Isabella to introduce our wonderful speakers who will spend time with us. Yeah.
Thank you very much. Our first speaker is in the person of Mrs. Adebukola Oluwabusayo. I hope I mentioned that right. And Mrs. Cole is currently the head of nursing at the Lagos Island Maternity Hospital. She has over 2 decades of nursing and midwifery experience. She has qualifications in general nursing, in midwifery, and ophthalmic nursing. And she's also a member of the National Association of Nigerian Nurses and Midwives and the Nigerian Ophthalmic Nurses Association. Currently, she's pursuing a fellowship program with the West African College of Nursing, and she's passionate about improving clinical care for patients and strengthening nursing services through quality leadership. Our second speaker is Mrs. Perpetual Ofori-Ampofo. And if for those of you who don't know her, she's the president of the Ghana Registered Nurses and Midwives Association. And before we admitted all of you into the Zoom, we were just discussing that she's a woman who wears many hats. So she does a lot of multitasking. She's the current chairperson of the West African Health Unions Network of Public Services International. And she serves on numerous boards, some of which include the Health Sector Occupational Pension Scheme and the Nursing and Midwifery Council. She's a foundation fellow of the Ghana College of Nurses and Midwives, and is also a member of STTI, which is an honor society in nursing. And she's also a Deputy Chief Health Tutor at my alma mater, the Nursing and Midwifery Training College in Kolebu. Our president has over 20 years experience in nursing, and she's passionate about strengthening trade unions, and she's also passionate about issues that border on social protection, migration, and adolescent and reproductive health. So we have two very amazing speakers today, and we are just here to share and to tap in the ideas. Please feel free to use the chat box. We want this session to be very interactive, and would like to hear from you. So if our first speaker is ready, the floor is all yours. I would like to remind you that you both have 20 minutes each to speak. Thank you very much. Please, Ma, we can't hear you. If you can please unmute yourself.
Yes. Can you hear me now?
Yes, we can hear you.
Yes. Good evening, Ghana. Good evening, Nigeria. Good evening, all the participants. It's my pleasure to be on board this evening. And I want to appreciate the organizers, the moderators, and mDOC Nigeria for the opportunity given. This evening, I will be presenting shortly on the respective maternal care, the midwives perspective. Can you please share my slide, please? Do you want me to share my slide, or you are sharing for me?
Please, if you could share your slide from your PC. Thank you.
It's saying you have disabled me to share my screen. Can you share for me, or you allowed me?
Okay, madam. So currently we are working on sharing for you. So kindly give us a few seconds, and then it will be projected soon.
Thank you.
Whilst we wait, I'd like to welcome those who have just joined us. So this is the third and final webinar in the Respectful Maternity Care series. You are most welcome. Kindly mute yourself and feel free to use the chat box. We are resolving this technical problem, and we'll just kick off shortly. Please bear with us. Thank you so much.
Yeah, I think my screen is online now.
Great.
Yeah. Safe Can I continue, please? Can I continue?
Yes, please. Kindly share your screen and then.
No, the screen is being shared by you. I can see now. Okay. Great. Safe motherhood is more than prevention of death and disability. It is respect for every woman's humanity, feelings, choices, and preferences. Respective maternal care is the universal rights of every childbearing woman. And my topic says, the midwives' perspectives, challenges, and way forward. This picture is telling us a lot, as we can see that haven't gone through a successful labor, haven't had a wonderful child, good looking, but the woman is still crying. This is telling us a story. The slide again, please. You've taken it away, the slide again.
Yes, so the issue is that you were the only one seeing it, we are not seeing it. So yes, exactly. So we are working on it.
Okay.
Yes.
Benson.
It's being shared now.
Okay, yeah.
Yes.
I think my time will start now.
I'm sharing it, so I can just forward when you tell me to go to the next slide.
Okay. I think I'm good here now. The picture is telling us a wonderful story. And it's telling us there's a question there. No, you have gone past. It's telling us, is surviving a childbirth enough? I don't know why this woman is crying. I don't know what she has gone through. I don't know what she's experiencing. Maybe it's a family issue. Maybe it's the aftermath of the labor pains. Maybe it's a financial constraint. Maybe it's lack of access to good quality facility. Maybe it's the kind of care she has gone through. Or maybe the abuse she has even received from the healthcare practitioner. But I know by at the end of this presentation, everything will be unraveled to us. We'll be able to know why the woman is crying, why she shouldn't cry. The next slide. Yes, by way of presenting this evening, these are my outlines. Next slide, please. Yes, in introducing the topic, it says, women experiences with maternity caregivers can empower and comfort them. This is a statement of facts that you and I, we have to believe in that it can make and it can mar. It can even tell you the kind of person you are as a caregiver, as a midwife, and even the facility in which the woman has even attended to. It's telling us that the caregiver can empower and comfort them or inflict lasting damage and emotional trauma. If you have come across of an abused patient or abused woman, you will know what we are talking about. They will tell you, no, I don't want to visit that facility again. That, oh, look at the way I've been treated. And another one is telling us that a woman's positive or negative memories of childbearing experiences stay with her throughout her lifetime. Yes, I can attest to this because I've gone through it. And I can tell you that of each of my delivery, I can tell you that I have a positive memories. Maybe because I'm one of them, maybe because of the facility which I registered and I gave birth to. Maybe because of the personnel that attended to me. But to some, it is not like that. Some will tell you, no, it's the pain we went through. Some will even tell you, I've even forgotten the labor pains, but the kind of abuse that we receive. Another one is saying, why many intervention aims to improve access to skilled birth, the quality of relationship with caregivers during maternity care has received less attention, which is true. Because when we look at the workforce, when we look at the workload, when we look at the quality of training in which the caregivers are receiving, then we'll be able to tell us that little or nothing has been done to training and retraining. Next slide. Now, this is not new to us, respectful maternal care. This is telling us, as a definition, this one is by Ra, 2011. It said it's a universal human right that is due to every childbearing woman in every health system around the world, which include respect for their autonomy, dignity, choices, and preferences, including maternity care. This one is, you can look at the pictures now. When you look, what we are seeing here is that there is no privacy, there is no dignity, there is no respect here. All these things shouldn't be if we want to go through the real definition. That is a universal human right for every childbearing woman. Every woman should have adequate access, should be given equal rights to enjoy and go through maternity care with ease and with a wonderful experience. Next slide, please. Now, the current state of care. However, evidence suggests that in countries with high maternal mortality burden, the fear of disrespect and abuse that women often encounter in facility-based maternity care is more powerful deterrent to use of skilled care than commonly recognized barriers, such as cost or distance. This is by Crott et al., 2009. What this one is telling us that in the countries that we have high maternal mortality burden, it is not that it is intentional. It is not that they don't want to have access to good quality care, but the aftermath of what they have gone through. Some of them believe that when they get to the hospital, the way the midwives will attend to them, physical abuse, emotional abuse, etc., made them to even prefer, oh, I'd rather stay at home, oh, I'd rather visit the religious home, oh, I'd rather visit the TBA. So this has, in the long time, increased what we call the high maternal mortality rates. Next slide. Now, we want to go through the categories of disrespect and abuse, and what are the comparative statements from the RAND baseline study. Like we have the physical abuse. You know, they will tell you, they beat us for the good of the baby. We shouldn't be. Why are we beating them? What is good for the baby? It is when we inculcate respect, when we respect their privacy, when we respect their confidentiality, that we'll be able to gain the cooperation. Their non-consented care, they will tell you, they will just cut you. They give you episiotomy without informing you. Those are the olden days practice, and they let you know, and they tell you that if they give birth at home, they don't go through laceration, they don't go through episiotomy, they don't go through any tear. In which if we go through deeply, we will know that there are a lot of laceration, 3rd degree, 2nd degree, etc. But in the hospital, because we know the reason why we are giving episiotomy, if we have involved them in their care, if they are aware of what they are going to encounter in labor, right from the antenatal care, that we need enough room for the baby's head, that is the reason why we are giving them episiotomy. And if we have even told them before we give episiotomy that, madam, this is what I'm going to do, they will not complain about non-consented care. Another one says non-confidential care. Yes, because some of us, I'm one of them, we are Philippine. We just say, oh, look at that motif. Look at her, why is she yelling? Why is she crying? Why is she shouting? Some of them, we just, look at her, she's been married again, I don't know why. Some of them, we even confide in us. By the way, when we are handing and taking over, we divert some that we are not supposed to have done. So they believe there is no confidentiality in the care we are giving to them. No dignified care. In the picture we have just shown, you saw a lot of women around the maternity area. So if we are going to manage these people, we should apply dignity. He said, am I the one that impregnated you? This shouldn't be hard. This shouldn't be told. because we are inflicting pain on their emotion. When you are having sex, enjoying it, did you not know it, what it will lead to? No, this is not. And I'm sure this has even gone past. In this era that we are right now, the 20th century is no longer in practice. We treat them with respect, dignity, and we apply our professionalism into it. Then discrimination. We shouldn't discriminate them, be it from Ghana, be it from anywhere, be it any race, any creed. Each we are one. It is the human right. It is the right of every woman to enjoy respective maternal care. Then abandonment, a lot of them, they say my baby was almost out before anyone helped me, which as a matter of fact, it is not like that. They believe that the midwife should be there with them, one-on-one. But when we look at my introduction, the third part, it says about the workforce. When we look, maybe a midwife to 4 women, a midwife to 3 women, a midwife to 5. How are you going to be? And some of them, because they don't have the knowledge of how to examine them and when to examine them, they believe they are being neglected. Another one said detention in facility. Some of them, why are they being detained? Is because the knowledge is not there. Why are they being detained? Is it because we want to check their PCV post-delivery? Is it because of lack of financial of finance? Is that the reason why they are being detained? But because the knowledge is not in there. So they believe that we abuse and disrespected them. The next slide. Yeah. Many women feel neglected by healthcare provider during this labor. Looking at this image from a Google image, we can see this woman was adequately prepared for. The labor is in active stage of labor, and is in active stage. The bed and everything was well made. The infusion is already there. But because of the lack of pain threshold that is so low, she believes that she's being neglected. She's complaining. She's saying, oh, look at them. I'm neglected. The healthcare provider, they are not there. And this can cause a lot of emotional trauma to the woman. But if you go at length and explain to them and start, oh, madam, this is that. I'm going to visit you, to examine you every 2 hours, every 1 hour, and so on. And I'm sure this will not be there. The next slide, please. Now, what are the factors contributing to disrespect and abuse? Number one, it's there, low socioeconomic status. Please, can we go back to, low socioeconomic status. It is these underdeveloped countries. You see majority of them, they believe that, oh, visiting a secondary facility, even the primary health care centers that is even closer to them, they believe it's expensive. They believe they cannot afford it. They believe, oh, when I get there now, the bill they are going to give me, I don't think I'm going to afford it. So I'd rather visit another place. Lack of education and empowerment of women. It is the time now for us to be educated. It is the time for us to be empowered so that we will be able to appreciate, we will be able to embrace the rights that we have. Poor provider training and supervision. This one, we want to say thanks to the government that they are doing a lot at this particular time, especially in my state where I come from, Lagos State, in the area of training and retraining. Because when you come out of school, we should be updated, in which the RMC webinar is all about. This is an avenue for us to learn, to know the new trend and update ourselves. And the seniors should be there to supervise. They believe that normalization of disrespect and abuse during childbirth, we shouldn't be. Some of them will say, when you get to that facility, it is normal for them to abuse them. It is the end thing. No, this is not. This cause it's another factor that makes people to run away from us. The weak health systems, inadequate staffing of health facility leading to work overload on the available staff. If we look at WHO to compare to what is available on ground, we will see that we cannot even mention it. So the system is weak. The government has to rise up and bridge the gap so that the staff will be enough and the workload will be reduced. Also, our facilities the environment should be welcoming. Should be welcoming. In some units, you may see no screen, in some units that are what we call the joint consultation, which shouldn't be. This is not the preaching of the respectful maternal care. Another one says lack of accountability and legal redress. This has to be addressed because they will tell you if they even make mistake, no sanction. If they make any mistake, no one to even correct them. Because of this, it causes a lot of disrespect and abuse. Next slide, please. Now, what is the way forward? That's the way of my recommendation. Education of girl child and women about their human rights. Since it is universal, respectful maternal care, it is universal. It is our right. When we know, this is where we come to. Everywhere we are, let's teach them. In the church, in the society, in the mosque, anywhere we find ourselves, let's teach our girl child. Let's educate them. Be it a teenage pregnancy, be it an elderly primate, be a multipara, let's tell them that it is our right. Let's empower them. Let's educate them. Also, let's empower women to reinforce their right to be treated with dignity and respect. In my facility where I come from, it is our core value here that all our women are treated with respect. We show empathy and we put in our professionalism. Then sensitizing healthcare professionals, training and retraining of healthcare professionals on patient-centered care. That is the aim why we are being called midwives. The aim of we being called the professionals, the healthcare practitioners, is because of our patients. So the training and retraining should be there. It should be ongoing. Let's attend a lot of MCPDs, please. Let's attend online trainings so that we'll be there and be able to deliver the quality care. Proper supervision of the staff. We have hierarchies in nursing profession. It is not for us to get to on top and believe, oh, I'm not going to supervise them. No, we should be able to remember the Bernard's theory from a novice to an expert. So the expert should be able to bring the novice to become an expert. We should have a proper supervision of our staff. Provision of enabling environment, infrastructure, and processes. Yes, this is talking to our government and to we, the managers too, that the available infrastructure given to us, we should be able to manage them. We should be able to use them to be able to give a dignified care to all our women. Also, the government should provide an enabling environment, a one-on-one delivery suite, a one-on-one care to all our patients. Make our consulting room friendly and welcoming. Also, the last one says that if we have any hearing member, we should be able to take care of them. There should be sanctions for any hearing member of the health care provider, especially with the midwives. In my facility, if you walk in, right from the gate, you have signages, you have telephones, lines that you can call in case you go through any form of abuse or not. And also on various platforms that we have in my facility, you can report any hearing member and trust us, sanctions will be done. Trust us that a punitive measure will be given to the person. Next slide. Next slide. Now, I believe we are so happy with this picture. Compared to the first woman, the very first picture on the second slide of my presentation that was crying, maybe abuse from a midwife, maybe the emotional trauma she has gone through. But just look at this woman. She's so happy with her child. Look at the midwife too. This is a patient-centered care approach that ensures a respectful maternity care. Next slide. Yes, in my conclusion, I want to say here that there's disrespectful and abusive behaviors undermines the utilization of health facilities for delivery and creates psychological distance between women and health provider. In the first webinar on RMC here, I went through those slides and I saw that if you want your facility to be known, if you want your facility to be well utilized, I believe we should imbibe the attitude, the culture of human rights, of giving a well behavior. We should be able to respect all our women and giving them the real RMC. Women in labor expect empathy. I've said it. They need us a lot. We don't need to abuse them. We don't need to traumatize them. Be it a teenage pregnancy, be it even unwanted, be it anything. So far, the woman has come to you. All we are there for is to put ourselves in their shoe. Let's show them empathy. Let's teach them. Let's give them quality information. Let them be able to trust us. Let's support them in their care. Let's, anything confide in us, let's keep them confidentiality and let us respect them. From their birth attendants, and that we should be cheerful to give to them to reduce maternal mortality. I want to say here that I have children that I have delivered over 25 years that still calls me, that still give me the due care, that their mom has even tell them, oh, look at this is the midwife that delivers you. Sometimes ago, I think January before the pandemic, a woman walked into my office. Little did she know that the lady she brought to my facility, I was the one that delivered her in another facility. She just mentioned and said, oh, madam, what is your name? I said, my name is Cole. He said, oh, have you worked in Randula Center before? I said, yes. He said, you have forgotten me. You delivered my baby at that particular time. What am I trying to say? Our behavior, our approach, the way we meet them can give them, is either make or ma, and it can give you a good recommendation to your facility or to even you yourself. Next slide, please. Next slide. Now, this is a woman. This is an example of a respective maternal care. At least you can see here the logo of my hospital. You can see here the baby. Despite what the woman has gone through, the woman got up. She was so happy to even embrace the bundle of joy. And I want to tell us here that it starts from you and I. Thank you so much. Next slide. The change starts from you and I. These are my references. These are my references. And I want at this juncture to say thank you to every one of you. God bless you.
Wow, God, Madam, this has been a wonderful presentation, and our guest has been Mrs. Oluwabusayo from Nigeria. I have learned a lot, and I know that you have also learned a lot. There's a need for us to respect the women that come to us to deliver, and we have to avoid negative use of words. I had a discussion with one woman in my community who has promised never to come to a facility that I don't want to mention the name again, because she was virtually, in fact, she was literally whipped by a midwife to open her legs. And she actually used the same words that Mrs. Oluwabusayo used, that am I the one who had sex with you, that you think we have time? You know, this negative experience at the labor ward has made this woman decide to always deliver in the house. Ladies and gentlemen, my name once again is Benson, and I'm one of your moderators. Before we continue, I really want to urge all of us that if you have any question based on the presentation that has been made, kindly put it in the chat box, and then we'll call you, or you raise your hands, we will unmute you, and then you ask your question. Before we continue, we want to know where you are now, the country and the city that you are communicating with us from. We want to know what you want to learn from today's webinar as well, though we've started already. And with all these things that have been said, it will be said, what does respectful maternal care mean to you personally? We would be so happy to hear from you. At this juncture, I want to leave it for Isabella to continue.
Thank you very much. Our second presentation is coming from our president, the president of the Ghana Registered Nurses and Midwives Association. And after she's done with her presentation, then we'll take questions, and then we'll just have a good interactive session with our presenters. Madam President, we are ready for you. Thank you so much.
Sorry, just a quick question. Do you want me to share the slides?
Thank you very much, Isabella. I'm sharing my slides now. I hope you can all see it. Can you see it, please?
Yes.
Yes, we can.
All right. Thank you so much. So good evening to everyone. And I am most honored to be here this evening to share some few thoughts on the midwife's perspective on respectful maternity care, challenges and the way forward. So the outline of my presentation will include an introduction, a historical view of maternal mortality rate in Ghana, structure of Ghana's health system, the WHO typology on disrespectful maternal care, the WHO 12 domains of respectful maternal care, challenges of respectful maternal care in Ghana, the way forward, and conclusion. So as part of introduction, I would want to say that according to the WHO, almost 99% of all maternal deaths occur in developing countries, with more than half of this figure occurring in sub-Saharan Africa. And the target of less than 70 deaths per 100,000 live births by the year 2030 under the SDG 3 requires more effort on the part of all stakeholders, considering that the MDG target of 190 per 100,000 live births was not achieved in 2015. And indeed, maternal mortality continues to be a great concern for the health sector in Ghana, with more deaths occurring in rural areas than urban areas. So on this slide, you are seeing the historical view of maternal mortality in Ghana. So from 2000, the year 2000 to 2015, when the Millennium Development Goals were institution, you could see that in Ghana, the maternal mortality declined from 484 deaths per 100 live births to 320 in 2015. Now, from 2015, as we all know, the Sustainable Development Goals have been also enforced, and as a target on the SDG 3, a lot of effort has been put in by Ghana to be able to achieve the required 70 per 100,000 live births by the year 2030. So in 2016, the rate was 314, in 2017, 308. And when you look at the other side, you are seeing that in 2018, the rate was 127 per 100 live births, and by 2019, it was 117 per 100 live births. So the current rate we have in Ghana is 117 per 100 live births. Now, the structure of Ghana's health system is such that we have tertiary hospitals, which are mostly the teaching hospitals, and at the moment we have 5. One in Greater Accra, we have one in Central Region, Ashanti Region, Northern Region, and Volta Region. Then we have the regional hospitals, and every region has a regional hospital. And then we have the district hospitals, followed by the sub-district hospitals, which are basically the health centers. And then we have the community-based health planning services, which are the CHIPS compounds in the various rural areas of Ghana. Now, most of the discussions we are going to have today are going to dwell on the WHO typology on this respectful maternal care. The evolution of words have come through so many years, such that at a point we used to hear obstetric violence, disrespect and abuse. We heard of mistreatment, and today we are talking about respectful maternal care, which has a broader domain. And in 2015, WHO did a study in various countries across the world, and they, through the systematic review that they did, they arrived at this typology of disrespectful maternity care. So we are talking about physical abuse, We are talking about verbal abuse, stigma and discrimination, failure to meet professional standards of care, poor rapport between women and providers, and then health system conditions and constraints. These are the issues that actually result or disrespectful maternity care can be attributed to. So we will move now to the 12 domains of respectful maternity care. According to the WHO, when we are talking about respectful maternity care, then we are talking about dignified care, which is free from harm and mistreatment, which ensures the maintenance of privacy and confidentiality, one that preserves the woman's dignity, and one that has a prospective provision of information and seeking of informed consent, ensuring continuous access to family and community support, enhancing quality of physical, environment, and resources, providing equitable maternity care, engaging with effective communication, respecting women's choices that strengthen their capabilities to give birth, availability of competent and motivated human resource, provision of efficient and effective care, and last but not the least, continuity of care. So these are the 12 domains of maternal maternity care. And please, let's try and keep this in mind. So when we take the typology of this respectful maternity care, let me say, we are going to discuss the challenges of respectful maternity care in Ghana. And when I accepted to do this presentation, I also, aside from my own experiences and from what I know that is happening in our various facilities, I took time to engage some of our midwives, the midwives in our membership, and I was privileged to host about 12 of them in a virtual meeting, and they shared a lot. So in this, on this slide, I'm going to share their perspective, the midwives' perspective on the typology of this respectful maternity care or maternal care. So the first is physical abuse. And when you talk about physical abuse, the midwives' perspective is that, you know, we don't go out to the hospital to beat our patients or our clients. No. What we are doing is that we are
Sorry, we are having some technical challenges with the internet.
Whatever it's, which is, and it occurs more at the public health. Hello? Hello, Isabella, can you hear me?
Yes, we can hear you now. The line was a bit choppy, but we can hear you now.
All right, sorry about that. So when, according to the midwives, when they hear physical abuse, it's not that they go to work intentionally to beat their patients, not at all. It's an intervention tap that is necessary to save life. And in fact, they also shared that there may be instances where this may go overboard, and this usually occurs at public health facilities more than private institutions. In terms of verbal abuse, the midwife's perspective is that letting the patient, it's about letting the patient understand and appreciate how critical the situation is, coupled with the fear of victimization of the practitioner in maternal or baby death audit. And this, I must say that, yes, there are instances where midwives go overboard, but most of the time, whatever they say is to enable the woman to understand that in that critical moment, she has a role to play in order to save herself and her baby. And more often than not, if a death of a baby occurs, or a death of a mother occurs, you are subjected to an audit process where you are stressed out because you need to put up reports, you need to answer questions, you go through a lot. And according to most of the midwives that I engage, they need to avoid this. They need to avoid this. So sometimes this happens. And let me say that Eugenia, whom I contacted from Upper East, shared that indeed in Upper East, they as midwives don't even have to do that. Most of the time, the mother-in-laws come in as companions, as labor companions, and they do a lot of the communication, encouraging the woman, and where they think that they have to raise their voices or say things that will encourage them to actually push or do whatever they need to do. That is the point at which the mother-in-law also plays a role. The issue about stigma and discrimination, it hardly occurs, although there is no doubt that when you take certain categories of our patients, like teenagers, very poor, mentally ill, non-compliant patients, and those with HIV/AIDS, those patients may experience care differently from those who don't fall in this category. Then failure to meet professional standards of care. Consent issues with vaginal examinations, induction of labor, episiotomy, and in some cases, cesarean sections are duly followed. And what we are seeing from the midwife's perspective, what we see that is happening is rather that not much information or education is given at the point where some of these interventions need to be put in place. So not much education. And when you consider the fact that the woman may already be in some form of pain or something, then it becomes a difficult thing for her to even understand exactly what you are talking about. Then poor rapport between women and providers. Poor rapport exists in the midwife's perspective today, and it's connected to the disconnect between services provided by midwives at the antenatal or pregnancy schools and those at the labor wards, coupled with inadequate preparation of the pregnant woman for labor. So when you take the antenatal clinic or area, the pregnant women through the antenatal schools and so on become very used to the midwives they engage over there, because they educate them, they share a lot with them, and then they teach them how to handle themselves during the pregnancy and what to expect during labor and so on. However, much effort is not put into bringing these women to see how the labor ward looks like, the circumstances under which they will be required to deliver, and all those things. So there seems to be some kind of disconnects between midwives who work in these two areas, and therefore it also results in some poor rapport between women and providers. And the ultimate, I call it the ultimate, are the health system conditions and constraints. And here in Ghana, the health system conditions and constraints are in existence, and in fact, it does not augur well for the practice of respectful maternal or maternity care. And in fact, the infrastructure is such that you sometimes have a woman delivering, and it's not just one woman, you have others around, you have other health professionals around, privacy cannot be maintained, even where there are provisions for you to have screened or put some curtains, those curtains are not available for you. So these are the very difficult situations, and I believe that in the discussions that follow, we'll be able to share a lot on these. Now, so how do we, still on the challenges, so you can actually look at all the challenges in three ways. The ones that are patient-specific, the ones that are midwife-specific, and then the ones that are system-specific, and that is health system-specific. So for the patients, inadequate preparation for childbirth and labor. There are instances where patients come in to deliver and they don't bring anything along, and they don't bring even a cloth that after birth can be used to wrap the baby. And in such circumstances, where does the midwife get all these items from? It's not like in other jurisdictions where there are a lot of these disposable towels and so on and so forth, and therefore a mother can come in empty-handed and still would have everything that she needs available. So it brings a lot of frustration for the midwife. And then sometimes also it's about inadequate preparation in terms of what to expect when it comes to labor and delivery. And coupled with the fact that people react differently to pain, you would have people displaying certain attitudes or behaviors that may not augur well for the midwife to assist and to ensure respectful maternal care. Then we have the non-application of knowledge and skills acquired during antenatal period. Yes, they will not apply it for some patients, but I want to say that this particular issue is not more about the non-application. I think all things being equal, every patient would want to apply the knowledge that they have. But of course, sometimes they are thrown off board because of the pain that they are experiencing, especially if it's a primip, and it becomes difficult to deal with this situation. Then stereotyping of midwives. Sometimes some patients have very difficult encounters with some midwives, and for that matter, they put all midwives in one category, and they view every midwife to have been or to be like the one that they encountered, and therefore it also doesn't help with building rapport between the provider and the patient. In ineffective birth plans, there are instances where women sign on as part of their plan that they do not want episiotomy. And it becomes difficult then to get the patient to consent when you have a big baby. And obviously you can see that you need to give an episiotomy, and yet the woman has signed, and in that circumstance, she says, no, there's nothing that you can do. Then varied pain thresholds. So we are different individuals with different body systems and react to pain differently. So women in labor, based on their varied pain thresholds, also may put up certain behaviors. Some need to lie on the bed. They will tell you they cannot lie, they need to roam. Meanwhile, head is in the perineum, and it creates a whole lot of distress and frustration for the midwife. Then you also have cultural influences. Various cultures, depending on where this woman is coming from, also has an impact on the attitudes and behaviors that the person displays. Then let's take the midwife, the professional. Most of the time, it's issues about burnout and what they describe as midwife's distress. So a lot of things are happening at the same time. You are having to make decisions on your feet, and then you have an uncooperative patient, and the workload is so much. And so it puts the midwife in a lot of distress. And those who don't have that emotional intelligence or that ability to cope, then they begin to falter in the way they are supposed to ensure that they provide dignified care to the patient. Then you have emotional trauma as a result of previous experience of death of a mother or baby. The previous experience of death of a mother or a baby in the midwife's perspective makes it difficult, in the sense that if she has gone through that process where a mother died in her hands or a baby died in her hands, she was subjected to this kind of audits, and she has to write reports, give explanations, and so on. Sometimes they may not even have done the delivery themselves. Sometimes they may have first seen the patient at the assessment stage, and then the patient would have moved on to a different stage, but everybody is boxed on together, and that experience alone can also traumatize the midwife, such that it influences the way she acts in terms of delivering care to her patients. Then fear of the maternal or baby death audit, and I've spoken about this. And also the lack of support from senior nursing stroke midwifery managers in terms of maternal or baby death audits. And this is very serious, because then what we are seeing is that where you are looking up to your superior to assist you to now understand the events that occurred, you are rather having a situation where the manager is more than willing and prepared to ensure that you get into that trouble and you are sanctioned or you are punished for whatever happened. And this does not augur well for the professional relationship that is expected, and it demotivates, and that's the next point. It demotivates midwife in the care that they give. Then frustration resulting from lack of equipment and human resource constraints. So one, not enough midwives at a time at a place, and then you need some equipment to work with and they are not there. So it's also a difficult situation. Inadequate communication skills. So yes, indeed, there are some midwives who don't know how to talk. Let me put it in quotes. They don't know how to talk. So where they need to apply emotional intelligence and then speak to the woman in a calm tone and then explain certain issues, they rather get frustrated, throw their hands in the air, and then begin to speak to the patient the way they will speak to their child at their homes. And this does not augur well for respectful maternal care. Then the issue about the disconnection between midwives at the antenatal and then the labor room. This, I've spoken about it already. And in the way forward, we'll talk about this. Then the lack of understanding of the friendly language of patients. You may ask, what is the friendly language of patients? You know, we are varied individuals and people react to things that we say differently. You will say something, somebody will just laugh over it and take it as a joke. Like my co-presenter said, you could say that, yes, when you were having sex with your husband, was I there, or am I the one who impregnated you? Somebody will react and just laugh over it or will not take it seriously. But there are others who take this as very, very offensive, and more so due to their cultural background. And therefore, we must understand the kind of friendly language that we can have with the patient in order that we don't disrespect them. And then the lack of emotional intelligence is very, very, very important. And we need to understand how we can control our own emotions in order to provide the requisite and respectful maternal care that we need to give. When you take the health system, inadequate infrastructure or improper infrastructure in some cases, lack of logistics and equipment. And in fact, this third point is very important. Many students on the ward needing to learn, resulting in unnecessary vaginal examinations. So you have a situation where a small bed capacity hospital, and yet because so many students are trying to learn at the clinical area at a time, you have medical students, you have nursing students, you have midwifery students, all sorts of students on the ward. At some point during the woman going through labor, when you take medical students, for example, they want to do vaginal examinations. If you are a preceptor or you are a mentor over there, also trying to teach your midwife, you need to let her also go in and do. So sometimes unnecessary vaginal examinations also infringe on the dignity of the patient, and this is very important. And when I had the virtual meeting with my midwives, I was telling them, I personally had to experience vaginal examination from a medical doctor, and I was like, wow, when the midwives did it, I didn't feel any pain. What kind of hands would you put in there such that I could feel so much pain? And that is some of the issues. So people do it, it becomes a routine affair, and therefore when they are doing it for a patient, instead of doing it gently such that they don't give unnecessary pain to the patient, it doesn't happen that way. Then we have understaffing at some facilities, and that is poor midwife-patient ratios. And these are issues that will require more training and so on. So understaffing, and of course, the equitable distribution of the midwives that we have. Some facilities. So at some facilities, you give birth to a baby girl and you're expected to buy a particular kind of cream. You now have to buy earrings. You now have to do this. When you give birth to a boy, maybe you need to do this. These are unexpected costs. And when you think of the fact that And there are some aspects of the national health insurance that does not cover certain things. It means the mother has to take care of certain bills. And then these unexpected costs also adds a lot of frustration and, in our view, does not augur well for respectful maternal care. Then inadequate pain management. And this is very peculiar with public institutions. You wonder, what are some of the protocols of pain management in labor for? If they are actually there, why are they not implemented? But you go to private facilities and it is there. The drugs that are supposed to be given to the woman from beginning to end that will reduce her pain, they are there to be given. What are we afraid of when it comes to the public institutions? It's like when you go through the pain, then you are a woman. If you cannot bear the pain, then you are not a woman. And not a woman in quotes. So some of these things will also have to be looked at. Then inadequate systems and processes of referrals. So the processes of referrals, of course, we know if you are moving from a lower stage of the health system to a higher stage, the referral has to be made and so on. But you realize that a woman who is in labor and needs to be transported, how is it supposed to be? You need an ambulance to do so. But where are the ambulances? In some circumstances, women are put at the back of motorbikes and trucks and all sorts of things in order to get to the next facility. And because of the poor road networks, especially in the hinterlands, it makes it very difficult to also transport mothers, although we know and appreciate that they need care at a point. There is an instance where a woman had a difficult labor and had to be referred. When the midwife moved her in a hired taxi to get to the next point, before they could get there, they had hints from other drivers coming from the opposite end that there are armed robbers. There are armed robbers at the end of the road, and therefore it is better they turn back. At the end of the day, because of fear, because sometimes these armed robbers will not even wait to see who is in the vehicle and will start shooting, they had to turn back. And when they got back to the facility, the midwife had to virtually beg the woman that, please, you need to cooperate with me. We need to do this in order that you can deliver safely, because at this time we are helpless. There's no help. After several coalitions, they were able to go through the whole process of delivery successfully. Then we also have the location issues. So road networks and so on, like the robberies that I have mentioned. Then you have exclusion of labor companions in labor processes. So there are instances where in some facilities, you are not allowed to bring in your labor companion, and therefore somebody you could have easily relied on, somebody who could have stayed by your side to rub your back, to encourage you and so on, it is not there. So you are left on your own and it becomes difficult to go through the whole system of delivery alone. So this is just a picture showing the midwives that are engaged: Eugenia, Rita, Celestine, Edith, Victoria, Dorcas, Veronica, Mami Fosua. I give you the credit for most of the information that I received. Thank you so much. And then how do we move on as a people? How do we ensure respectful maternal care? So when you take the patient-centered issues, then these are but not limited. We need in-depth education about labor and what to expect. We need psychological preparation before labor. I'll continue on the next slide. But here, in terms of the midwife, maintaining professional standards of midwifery care, which is very, very important. Continuous professional development, very important. When it comes to the health system, we need improvement in health sector budget allocation. And it's important that we get government from where I sit as a trade unionist. We'll continue to talk about this. It's about time the budget allocation for health. It's tagged at 15% or more, because government signed on doing the Abuja declaration some years back to allocate 15% of the nation's budget to health. And when you have these monies in there, then it makes it more easier to improve infrastructure, to renovate existing ones, to train more personnel, to do a whole lot more. So we'll continue to ask for that. I know in Ghana, we are hovering around 10.5, 11%, and we are not there yet. So there's still a lot of room for improvement. Then improvements in health sector infrastructure, provision of requisite equipment and other logistics, development and proper implementation of labor pain protocols. So it needs to be implemented as it is, and we do not have to allow our women to go through unnecessary pain. So in addition, orientation of the patient to the labor room and staff before due time, and then of course, better preparation for childbirth. And then on the midwife side, communication skills and emotional intelligence training of midwives. And of course, the collaboration between antenatal center and labor room midwives on education of pregnant women is very, very important. And on the health system also, full implementation of labor companion protocols, and then the reintroduction of the post-basic midwifery programs for nurses. At the moment, we have a lot of nurses in the system, but limited numbers of midwives. And maybe it's about time we reintroduce the post-basic, where you go through nurse and you want to do midwifery, you can still go and do midwifery. And although we have advanced as a country, you know, you can go and do a first degree in midwifery and further on do more in terms of even the specialist programs. But we are talking about just a fast-track system where you have nurses who complete after a certain number of practice can adequately do that previous 1-year midwifery program. They become midwives and they can also assist the system. There are improvement in road networks and referral processes, improvement in conditions of service of nurses and midwives. Yes, it takes a motivated nurse, a motivated midwife to give respectful maternal care. So the conditions of service is also very important. And in this case, it's not just about what we sign as a union with our employers. I think facilities, based on what they receive, can go a step further and provide certain incentives for midwives at their various facilities. So in conclusion, I would like to say that respectful maternal care or respectful maternity care is a human rights issue and must be applied in all situations despite the challenges. Women in labor are at their most vulnerable, and their care must be holistic and centered on their individualities as patients. And of course, governments, employers, and other stakeholders have a daunting task to ensure Ghana achieves the SDG target of 70 per 100 live births by the year 2030. And let us all realize that respectful maternity care, coupled with an improved health system and a well-motivated team of midwives and nurses, can enable us to achieve same. So thanks for listening. And over to you, Isabella and Benson.
Right, thank you very much.
Thank you very much.
Madam Perpetual Ofori, for such a wonderful presentation. Madam Perpetual Ofori is currently the
Ofori-Ampofo Benson.
Ofori-Ampofo is the president of the Ghana Nurses and Midwives Association. Right, so we'll be moving on to question and answers. If you have any question that you want to ask, if you have any suggestion, what we would want you to do is just look down on your screen just below. You will see a reaction button. Once you click on it, you would be able to raise your hands. And once you do that, Isabella and I will call you, and then you ask your question, which will be appropriately answered. What we are going to do is that we'll take about 3 questions together, then it would be answered. Thank you very much. So please, if you have any question, you can even clap your hands from the presentation. Once you click on the reaction, if you want to clap your hands, you see that hands clapping, and that's a virtual clapping, you know. And if you want any questions that you want to ask to, kindly raise your hands and we'll call you. So whilst I wait for questions to be coming. I want to ask, Madam Mrs. Oluwabusayo, does allowing a husband at the labor ward a way of contributing to a respectful maternal care? Because I have seen instances where husbands really want to come in, to even come and take videos, which they have consented with their wives, but the midwife will insist not in my labor ward and sack the husband. Does that contribute to a respectful maternal care? Should we allow them to come in?
Yes, thank you very much, Benson. I think we should allow them. It depends on the facility. I'm going to talk precisely about my own facility here. We have 2 suites in Lagos Island Maternity. We have one that is a delivery suite, and the other one, we call it a birthing suite. In the birthing suite, you are allowed because it's a one-on-one. It's a suite that you are the only one that is going to be there during labor. Your mother-in-law can be there, or your mom and your husband, and you are free to do whatever you like to do, thereby dignifying the care, thereby enhancing even your state while you are in labor. While the other one, the delivery suite, is a 4-bedded ward that accommodates 4 women at the same time in labor. In that area, because we want to give respect to their privacy, we don't allow their husband to come in, although we explain to them. And all this teaching we're talking about start from antenatal clinic. We let them know the tool that we have and what it entails to participate when they are in labor. Thank you. Hello, Mr. Benson. I'm done. Can you hear me?
Thank you. If you have any question, you can unmute yourself and ask our presenters directly. Thank you.
Hello.
Yes.
Hello.
Thank you for the presentation. My name is Alberta. Listening to the presentation, it sounds more like quality assurance kind of pathway. And sometimes I got opportunity to work at the district hospital for some time. And then with this particular topic, having a respective maternity care, sometimes when you go to the district hospital, it's just like a midwife being given an injection and saying that you should smile at the same time, because you realize that a midwife goes to the ward and properly is using a torchlight to deliver a woman properly. At this stage, the woman might need episiotomy. How possible can this midwife give all the respect that the woman will need at that particular time? Or probably would have to walk in the rain and go to work, or the person's psychological even needs are not being assessed as a midwife. Probably even that moment, the daughter is also sick, admitted at a particular hospital, or the husband is dead at that particular. All that the in charges would want is you are supposed to come to work, and that is it. So I feel this particular topic it should be like a hand-to-hand kind of thing. If a midwife is happy, definitely is going to give that respect to the pregnant woman. As the second presenter said, I think he made mention of some of the things that I was also thinking about. And then another point is that these same women, midwives that are working in Accra, working in the government sector, would also want to have a part-time work in a private hospital. They give the due respect to all the women that come to the private hospital. But when they come to the government sector, the difference, you can see it clearly. What then causes that? Is it that there is something so special about a private hospital that the same midwives that are working in the government sector will close and then go to the private sector and give the respected needs for all that, the needs that the pregnant women, but when they come back to their workplace, they show disrespect, and then some of all these things that we have mentioned. I think that would be my question. But if you should also work at the private hospital, you could realize that it is not about they being paid well, but the point is that they have well-structured rules and regulations that if you don't follow, you will be sacked, or you will definitely be sent even to sometimes to court to go and answer questions on how you treat the women. Is that same thing applied to the private government sector? So maybe we can also look at that too. And then for the protocols, our second presenter talked about the protocols. For example, for some hospital, I've not really seen a lot of hospitals having protocols on how to sign consent form for episiotomy. And I think that probably this kind of protocol should come out, should even start at the antenatal, so that they can start preparing the mind of this pregnant woman before they get into labor, so that in case the woman will need it, as soon as the midwife says it, it will be very easy for the woman to accept, and then that respect will be offered. Thank you.
Wow, thank you very much for your question. We have noted it down, and after taking 2 more questions, it will be answered. I see Al-Hassan. Al-Hassan has also raised the hands up. So Al-Hassan, let's hear from you as well.
Good evening.
Good evening.
Yes, I'm so happy to hear all the speakers, and what Madam Perpetual said too is true. But my question is, these midwives and nurses, I went around in some of the parts in the Upper East region. Most of the women were complaining that because of the utterances the midwives and the nurses make, it prevents them from coming to the hospital. They prefer seeing a traditional birth attendant than coming to the hospital, because at times they are dressing, not always that a person should have the beautiful cloth or the wedding gown or what to attend the clinic. And because of their dressing, they look down upon them. In most of the hospitals, this is what is being done. So most of our people prefer delivering at home rather than coming to the hospital. So the midwives and the nurses, it's high time they try to pamper these people a little bit. Because I heard somebody saying, am I the one who pregnated you, or when you were in bed with your husband, was I there? And some of them, even when the people are in labor, they used to beat them, which is very bad. Beating them is also not good, it's also an offense. So I'm pleading with the nurses and the midwife to be patient with the pregnant women or those in labor. And some of them too are young, so at least something should be done. And also I was saying that if this national health insurance, at least when they say it's free, some are not free. When the medicines are so costly, those ones are not free. But if it's paracetamol or those fosiliates and whatnot, as for them, they are easily given out. But the costly ones are not for national health insurance. Why is it so? Thank you.
All right, thank you very much, Al-Hassan Sawaratu. So I will take the last question, and thank you for your contribution as well. It's well noted. So we will answer that. That will go to, on the national health insurance, Madam Perpetual will address that. So I want to go to Nigeria. Chidundu Madu Okoli. Yes, so we want to hear your question, and then once answered, Isabella will ask the next round of questions.
I think the person is not available, so let's take somebody else. I see Linda. Linda, are you ready to go? Please unmute yourself and give us your submission. Hello, Linda. Gifty? Gifty, can
Hello,
you
good
unmute yourself? Hi.
evening.
Yes, we can hear you.
Okay, so I think, yeah, I can go ahead. My name is Chidindo from mDOC Healthcare, and mine is just like a contribution. What I wanted to say based on the very insightful things that the speakers have put out today is that I think that one practical way to solving this, as in the challenge that we usually encounter, especially with antenatal visits and all, is something that I have seen based on where I've worked, and it's basically having the nursing and the midwifery team, or the people in the labor unit, set up sort of like a QA sub team. And that QA sub team, part of their work as in quality improvement is to make sure that every woman who comes through the labor ward and feels this patient satisfaction survey. So more like they have to answer questions about what the delivery process was like, if they have any challenges, and then the team makes sure that they get to review that weekly. So for instance, maybe in a week, they find out that, okay, a patient complained that somebody was probably disrespectful to them. They probably didn't mention the name, or they had issues accessing a particular equipment or tool to be able to take care of her. That's like something that is important for the QA team to address for that week. And I think with that, there's room for improvement in the process, and people get to know what to do better from both the patient's perspective and from the perspective of the people who are delivering the care. Thank you.
Yeah, Chidindu, thank you very much for your contribution. So let's go to our speakers, where Mrs. Oluwabusayo will answer the first question, and then Madame Perpetual will answer the second one on the national health insurance.
Hello, Mr. Benson. The first question again, please. The question again. Hello? The question again.
Hello, Benson. I was lost for a second. I didn't really hear the question that he asked you. So
yes.
I think he's, I don't know.
I was thinking the question is not for me, but can I hear the question again?
All right. I don't know. We can't reach him at the moment. So there are other people waiting to ask questions. So I'll just ask Jane. Jane, are you ready with your question? If you can unmute.
Yeah, hello, please can you hear me now?
Yes, we can hear you.
Okay, so the first one was to ascertain whether respectful maternal care is more of a quality assurance. And then the second one was for Madam Perpetual, where she wanted to know why national health insurance doesn't address this.
Okay. The first question about quality assurance, I can say that is they work hand in hand. The last contributor now said something about the Q&A, ensuring a survey maybe at the end of every week in the labor ward to ensure to see when each patient feels a survey, and we'll be able to look at it. So to be able to ensure that the facility is really practicing respective maternal care, I think the quality assurance should be involved, because it is not for us to say that this is what we want, that is the right of every woman, and at the end of it, we are not practicing it. So how do we know that it's being done? How do you know that those that are on ground, maybe during the afternoon shift or the night shifts, they are really doing it? Is it the morning shifts that is really carrying out what we call the respective maternal care? So I think they work hand in hand, and I believe it's a teamwork and it's achievable. Thank you.
Right, thank you very much, Mrs. Cole Oluwabusayo. So they work hand in hand. I would want to move to Madam Perpetual to talk about the essence of NHIS being incorporated in here.
Hello, Auntie Pep, can you hear us? I think we can't, I don't know if her line is the internet.
Okay,
can
so
we take another
whilst
question
we
whilst
wait
we wait?
for her to unmute. Whilst we wait for Madam Perpetua to come on board, we want to invite Matilda Sogolo to ask her question. Hello, Matilda.
Yeah, hello. Good evening.
Hello, Matilda.
Thank you so much for the opportunity. And please, mine is not a question, it's just an appeal. You know, even though RMC is centered on midwives, I am appealing that we also help clients to understand themselves and also respect each other, because some of their attitude tend to tarnish our image. And then the decreased attendance at the antenatal, labor, postnatal also affect our work and dignity. I'm saying this because one, I recently attended a conference and the Queen Mother made an appeal that in her town, which is somewhere in Kumasi, the teenage pregnant mothers refused attending antenatal care with the reason that the elderly pregnant women were verbally abusing them. So after the conference, I approached her and then suggested to her to contact the midwives at the facilities to engage them to dedicate one day of the week to only teenage mothers, whereby they will not mix them up with the elderly and then cater for them. So apart from we the midwives, you know, observing RMC, I believe we can also impart this same knowledge to our clients to also respect each other and understand each other. Thank you very much for the opportunity.
Right, thank you very much, Matilda Soglo, for your priceless contribution. I want to call on... Great. Madam Perpetua, you're welcome once again.
Thank you.
So we wanted to, someone asked the question, Chidundu, this one was Chidundu, wants to know about the incorporation of national health insurance on respectful maternal care.
Yes, so I saw his submission as more of a contribution than a question, because I think he was also talking about the difficulty in terms of some of the drugs not being covered by the NHIS, and for that matter, the woman is burdened, the pregnant woman or the woman in labor is burdened with costs to cater for some other drugs. And when you have a situation where you have a poor patient or somebody who doesn't have that affordability, then it becomes a difficult thing, because then it comes back to respectful maternal care, because at that moment, because those drugs are not available, you cannot provide them to continue the care or to give the requisite care that is given. So it is linked in actual fact. And I think we all have, as stakeholders, have to work together and ensure that the scope of the NHI is continuously broadened. I know it has been worked on in the past, but we have to continue opening it up such that it will cover most of the treatment regimes in various categories of healthcare delivery, especially when it comes to maternal care. Thank you, Benson.
Right, thank you very much, Madam Perpetual. I would now want to call on Gifty Foko. Gifty Foko, if you can hear me, we would want to hear your question now.
Hello.
Hello, Gifty.
Good evening.
Good evening.
Please, thank you so much for the presentation. Mine is just a small contribution. We the midwives, we are supposed to let all our clients feel free, like they should move about when they are in labor, because it helps them to feel so relaxed. The pain is not so intensive, and then it helps the labor to like shorten, because most of the time we tell them to lie down on their side, and then all these do not like give them the should I say the respect. Okay, we should let them be free, move about, and then when there is time for you to go and like check their fetal heart rate or do any procedure for them, they can now come and lie down for you to work on them. Thank you very much.
Right, Gifty, thank you very much for your contribution. Dr.
All right.
Boache. Dr. Preeclampsia Boache, I see your hand up. Okay, so if Dr. Preeclampsia Boache is not available now, let's move to Dorothy Achampong. Dorothy, if you can hear me, we are waiting for your question.
Alternatively, you can also type your questions and your suggestions in the chat box, and we'll read them out. Sasha, can you please help us with some of the questions and comments that have been typed in the chat box?
Absolutely. Amelia says, I believe if holistic care is given antenatally, the end result shall be successful. We also have from Olatan, from another perspective, a patient might not even know she had been abused. And so to solve this problem, women empowerment and education is important.
Hello?
Isabella, we can't hear you.
Sasha, can you hear? Can you hear me now?
I can.
The line is a bit choppy, so we can hear you.
There's this,
Okay, I think it's better now.
yes. So we have a few more questions from people. Aisha, do you have a question? I'm going to ask you to unmute. Aisha?
Okay, before Aisha unmutes, someone wrote a comment very thought-provoking. The person said, please, my humble suggestion is that this topic of respectful maternity care should be added to the nursing training school's curriculum. And
Hello?
Can you hear me? Yes, so this comment was from Mrs. Gifty Beidou. We also have another comment that said that women should also be involved in their care, their input as regards their choice of birth, where and when they want to have their birth should be respected. This will make them have a sense of control of their own care and delineate the feel of being disrespected.
That's very interesting. So there are more hands raised up. I want to come to Kendra. Kendra and Njoku, if you can hear me, let's hear your question. I'll take 4 more questions. So Kendra, let's hear you. Hello, Kendra.
To mute. Okay, thank you. So my question, it's really a comment. So the women need to be empowered to have the right expectations, right? And know and recognize abuse and demand their rights. Communication is also key when accessing care. Communication between the healthcare worker and the woman. So respectful maternal care is, involves the doctors, involves the cleaners, involves the nurses, the record staff, everybody that has to go with that woman. And so a woman might feel like she has received disrespectful care when she doesn't understand the context. So a high-risk pregnant woman might be receiving more frequent checks in the labor room. And this other woman who is not high risk might feel neglected and they're playing favoritism. So communication is really, really key. And also as we think about the use of quality assurance methods to get feedback from the moms, we need to also understand the context that we live in, that many moms, the point of taking that survey is really, really important. That if you take that survey while they're within the walls of the hospital, it influences sometimes their answers, and they're scared about whether that would influence future care. So we have to be innovative around how and when we take sincere feedback from members. I know that at mDOC we're currently putting onto an online directory of health facilities the opportunity for patients of a facility to go there and grade and score the facility. So even as you think about innovative ways to collect this information, just think about bias as well, so that we don't pat ourselves on the back just because people are underreporting.
Right, thank you very much for your contribution. So I have 2 questions here. The first one, I'm directing it to Madam Perpetual. So Prince Niza wants to know that amidst COVID-19, what has our health authorities done to curb teenage pregnancies, since a lot of teenagers are idle these days and might fall prey to pregnancy, dwindling their dignity? So, Madam Perpetual, you want to address this?
That's a really interesting question, but you ask yourself, during the lockdown and the period afterwards, has it been only teenagers who have been at home? I think that maybe in the next couple of months, we are going to see a lot more women pregnant, and by the 9th month, a lot of deliveries that are going to occur in our country. But the point is that you were asking whether health authorities are doing anything to curb teenage pregnancies. I don't think that there's much going on. I know that the adolescent health units under the Ghana Health Service does a lot of outreach in terms of reaching out to teenage women through the adolescent contraceptive clinics that are attached to some health facilities, and also reaching out to teenagers through in recent times, some virtual means. But all in all, the responsibility lies with parents. And I think that a lot of responsibility is with parents to find a way of educating their teenage children, especially young women, to let them appreciate the issues that come with teenage pregnancy and delivery and so on, so that they will wait for the right time. And of course, apply the ABC methods of ensuring the avoidance of unwanted pregnancies. So in terms of the health authorities, I'm not aware of much except for what I have shared with you. And it's about families and about parents and engaging their teenage daughters to understand some of these things. Thank you, Benson.
Right, thank you very much. Let me move. I have, after this, I'll ask the last question will be asked, and then we'll move to the last session. We really want to stick to time. So Rebecca wants to know, this questions go to Mrs. Oluwabusayo. Rebecca wants to know that how best are we going in giving pain management during labor? You know, it's very common in our African setting that if you don't experience the pain of labor, you are not a woman. Hence, people are being forced to endure labor, leading to being lashed among others. So she wants to know, Mrs. Oluwabusayo, what is being done currently to reduce pain during labor?
Yes, in my facility, Lagos Ghana Maternity here in Lagos, Nigeria, there are protocols for pain management. And we don't start until the patient is in active stage of labor, when it starts from 4 centimeters. We have epidural, which we do right now, epidural bathing, and is on request. If the patient has a low pain threshold, all these things are being taught in antenatal, and we let them know the options which they want to take. So if you come to our facility, we let you know. But starting from 4 centimeter dilatation, we institute a pain management. We use petidine, we use epidural, and so on. So we have effective way of managing pain. Thank you.
All right.
Thank you
very much. Thank you very much, ma'am. Before we end the questions, I just want us to reflect on these 3 questions. The first one, what makes it hard for you as a midwife to provide respectful maternity care? With this, what we mean is, are there any situations, problems, maybe types of clients which make it harder to ensure respectful communication? I want you to think through this, and I'll give you a few minutes to type your answers in the chat box. And I also want you to think about how midwives can be enabled to provide respectful maternity care and promote a positive birth experience. So you can type your comments and your ideas in the chat box, and we'll read them. And we also want to find out, for those of you who have attended the first 2 in the series of 3, and on respectful maternity care, what is the takeaway for you? What would you remember about respectful maternity care? What do you intend to incorporate in your practice, either in Ghana or in Nigeria? And we just want to hear your thoughts and your comments concerning this. If you can please type in the chat box, I'll read them out. Thank you.
do in this case?
So the chat box has suddenly become very quiet. This is not an examination. We just want to know your thoughts. So just let's hear from you. What do you think makes it hard for you as a midwife to provide respectful maternity care based on your experience? I'm sure you've taken care of lots of women. What makes it hard for you to provide respectful? Just a sentence will do, just a few words. And how do you think that as midwives, we can be enabled to provide respectful maternity care so that we can make the whole birth experience more positive for women? And if you've attended more than one of this respectful maternity care series, what is your greatest takeaway? I'll start with the bottom. So for me, the greatest takeaway from all of this is about partnership and empowerment. So I believe that in respectful maternity care, it's more like a two-way street. The midwife has her role to play, and the woman must also come into the whole midwife-woman relationship with an open mind and be empowered to actually participate in her care and also to build a trusting relationship with the midwife. And the midwife must also empathize with the woman and must give culturally appropriate care that is based on evidence. So respectful maternity care for me also has to do with evidence-based practice. So let's hear from you. What do you think RMC is all about? What is your greatest takeaway? All right, reading a few of the comments, Christiana says, it becomes hard to provide respectful maternity care when the workload is too much. An overly tired midwife is definitely bound to flare up. And Rita also said, we need to see ourselves as providing services for our clients and not lording over them. As such, we need to give them information and guide them to make choices and not push decisions on them. Judith says, what makes it hard for me to provide respectful maternity care is the type of client. Judith, can you tell me what you mean by this? Just elaborate a little bit. Seraphine says that it's not possible to allow women to use the position they like. So that she considers to be a hindrance to RMC. Mabel says that sometimes understaffing in some facilities puts pressure on midwives, and also the mentality of some women about nurses and midwives makes it difficult. We also have Victoria saying that she's suggesting that logistics must be provided so that midwives will not be frustrated, and because when they are frustrated, it also contributes to disrespect. Thank you very much for your comments. Grace says that work pressure, the number of birthing women, and patience, having the patience to take care of the woman can also contribute to disrespect. And Huawei Y7 Prime, I don't know who that is, says that some clients says that most of the women lack knowledge on planning. So it is difficult because most of them are already stressed. So you are talking about the fact that the woman is already stressed. And if you can explain a little bit, that would be fine. But thank you for your comments. And yeah, the comments are coming so fast, I can't keep up. Antonio says that I've had a very bad experience as a primate during my first delivery, and I wouldn't want anybody to go through that. So as a nurse, I'm going to ensure that women get the best and respectful maternity care as much as I would have wanted. Thanks for this webinar. Thank you, Antonio, for joining us. Dorothy says that adequate and proper communication, adequate provision of logistics, both human and materials. Temi Tayo Oluwole says that lack of resources, lack of a conducive working environment, the workload, and lack of cooperation from clients makes it hard for midwives to provide respectful maternity care. Emilia says that creating an enabling environment for the workforce is actually something that can improve respectful maternity care. And patients also says that not having the needed resources is really difficult and hard. So thank you very much for all your comments. Thank you very much for all your suggestions. You have made this webinar very interactive. Time is fast spent. So we would like to wrap up. Before we wrap up, I hope you all enjoyed this amazing presentation. Thank you to our two presenters. And this concludes the webinar of the three-part series on respectful maternity care. We hope that you have learned and enjoyed the presentation. And I want to especially thank our speakers once again. Thank you for partnering with us to communicate this very important information. So certificates of participation are available at a cost, 55 Ghana cedis. So if you would like to have a certificate, because this program is accredited by the Nursing and Midwifery Council for CPD points, so you can please register using the link. And we'd also like to hear from you. So use the link to give us your feedback. We have an upcoming webinar on the 4th of December, and it's about the Patient Learning Series 3, and it's coming on the 4th of December. So the flyers and the links to register will be made available on our social media platforms. Benson, I think you should take up from here.
Yes, so I want to also thank all of you. I mean, I'm so happy that we had almost 200 people joining us for this webinar, and I know that it's even enough to go and make things better in our wards and the society as a whole. So I also want to take this opportunity to thank the webinar planning team members, Dr. Linda Hinkra Fonjo, Dr. Charles Bachman, Dr. Vivian Echiapa, Dr. Dorothea Obri, Dr. Joyce Brown, Dr. Emmanuel Sofenyo, Dr. Clat Old Louis, I hope I got the name right, Dr. Bridge DeCock, then Kowako Labi, and then also the APECGH partners and collaborators in the organization of this program. The sports study, you can read more on us on the sportstudyghana.com. The Greater Accra Regional Hospital, formerly known as the Rich Hospital, the mDOC in Nigeria, and the Quick Medical Consult. I have been one of your moderators. My name is Owusu Benson, and I'm here with
Isabella Gatti. Thank you so much for joining us, and enjoy the rest of your week.
Yeah, thank you very much.
Thank you. Good night.
Good night.
Good night.
Bye, everyone.
Bye. Good night.
Bye. Thank you.
Thank you, Benson. Thank you, Isabella, for you are here.
Thank you very much.
That was really hard. I didn't think it was going to be this hard.
I realized that you were struggling, but